Okay, welcome to Pediatric Grand Rounds, everybody. I'm going to hand it off to Dr. Mel Hyman, our Vice Chair for Faculty Development, to introduce our speaker for today.
Thank you, Dr. Hirsch. It's my pleasure to introduce my friend and colleague, Dr. Laurel Leslie, who is the Vice President of Research at the American Board of Pediatrics and Professor of Medicine and Pediatrics at Tufts University of Medicine in Boston. Developmental behavioral pediatrician, Dr. Leslie's research has focused on the implementation of guidelines and policy initiatives, comparative effectiveness of pediatric screening and treatment, and collaborative models of care across sectors that incorporate the child and family as active participants in care. Dr. Leslie is also committed to improving the future of physician training and practice. She received her medical degree from the University of North Carolina at Chapel Hill and a public health degree from San Diego State University School of Public Health. But most pertinent today, she has a significant UCSF connection as she served as a resident and then as chief resident and finally as a fellow in behavioral and developmental pediatrics while at UCSF. For the past several years, I've had the pleasure of working under her as she is helping to lead the American Board of Pediatrics project, Roadmap to Resilience, Emotional and Mental Health, that you will hear more about today. Today's talk is entitled Easing the Emotional Disease of Children with Chronic Medical Conditions and Their Families. Welcome, Laurel.
Thanks very much, Mel. I'm delighted to have this opportunity. I really have nothing to disclose today except that I was a resident fellow at UCSF, as Mel mentioned, and that is part of who I am today. Mel has heard this story before, but he took me as a resident up with him to Marin County. There was a girl who was about 7 years of age who had short gut syndrome and was on TPN. And we went up and he presented to her a school classroom and answered questions that they had and so skillfully led a discussion with the other students around their own experiences with other family members who might have chronic illnesses. And it was a very meaningful experience and probably part of why I'm doing what I'm doing today. I wanted to just quickly ask Charisse if she could do a brief poll with you all, pull the poll up. And there are 3 questions on the poll, so you'll want to scroll through the questions and answer those questions, and then we'll look at them together. And just go with your quick instinct. This is not going to be shared with anyone except everyone that's on this call. So you should have a window that had popped up on your screen. We'll give it a few more seconds. And Charisse, how about we close it now and pop it up? We'll see what we've got. So the first question was basically asking how aware people were of the link between behavioral mental health, or what I'll be using as BMH on the slides, and physical health for children with chronic conditions. And we've got about two-thirds that are coming in as moderately to very aware. And then have you ever had the experience with a particular child or family that has brought home to you this link? And about 88% of you have had that with a patient. And then how often do you ask children with chronic medical conditions and their families, how are you doing, specifically targeting behavioral mental health needs? We've got about, again, about 2/3 doing this often or almost always, which is great to see. We can close that now, Charisse. And what I'm going to be doing is just discussing briefly the bidirectional links between pediatric chronic medical conditions and behavioral mental health, sharing you with about an initiative that we're working on at the American Board of Pediatrics with members of the Council for Pediatric Subspecialties and the Association of Pediatric Program Directors that really is looking to support children with chronic medical conditions and their families, and promote healthy behavioral, mental health, and emotional resilience. And then share some strategies for you all for attending to behavioral and mental health among children with chronic conditions and their families. So just to start off, children and youth with special health care needs, if we look at data from the 2016 National Survey of Children's Health, make up to close to 20% of children and youth in the US. And that definition includes children with medical, developmental, and emotional behavioral needs. It's actually increasing up from 15.1% about a decade ago. And I just highlighted a couple of challenges that children with chronic conditions often face. You can see in this first bullet that 29.6% of parents report inadequate insurance coverage, compared to 23.6% of those who don't report a child with a special healthcare need. And we see racial and ethnic disparities in the prevalence, resource use, and survival rates. And of those 19.4%, about one in 20 of all children, so a proportion of those with special healthcare needs will have a severe disability. Now that impacts both the child and the family in multiple ways. And I can remember being in the developmental behavioral clinic there at UCSF, and one mother crying, just worried that her eating an entire carrot cake during her pregnancy led to her child having autism. And we might, find that amusing or sad, but I think about the fact that this was something that was so concerning to her that sharing that with a pediatrician and getting rid of some of that guilt about causing this condition was actually a therapeutic experience. But there are worries about the child's health, future career, marriage, mortality, how much attention that child is getting compared to siblings. Monetary concerns are also very real, including food and housing insecurity. Depending on the condition, it may limit social opportunities and lead to isolation. And then we know that our clinic visits, health status checks, procedures, hospitals, side effects, and complications of what we do all can impact the child and the family, can also impact their engagement with school, can lead to stigma. Racism can also be a factor in how families experience a child with a chronic medical condition. And legal issues can arise. And then we've all seen over the last year how COVID-19 can dominate the experience of families of children with chronic medical conditions. And the consequences of those chronic medical conditions can include increased prevalence of behavioral mental health and disorders for the child, parents, and caregivers or siblings. And really, there's good data now, not only showing that it impacts the child's school performance, career paths, income, and overall health, but also the parental and caregiver health and longevity, as well as the siblings' behavioral mental health. And we know that how a parent or caregiver is coping also impacts the child's chronic medical condition. And that the cost for healthcare for those children who have a coexisting behavioral and mental health comorbidity is about 2.4 times larger than for those with just a chronic medical condition alone. So just to give you some examples, the Cystic Fibrosis Foundation, for example, has looked at rates of anxiety and depression among parents in the first 3 years post a diagnosis in the neonatal period. And 40% of mothers have symptoms of anxiety and depression, 30% of fathers. When children are status post a bone marrow transplant, you see about 50% of those children meeting diagnostic criteria for an anxiety disorder, and somewhere close to 50% of their parents meeting diagnostic criteria for depression disorder. We also know that there's emerging data coming out on mind-body interactions. So this is a paper that came out in 2020, looking at the impact of depression in children with obesity and asthma, and demonstrating that the addition of depression into their symptom profile impacts FEV1 and airway resistance, which in turn impacts depression. And we also all know from our own experience that our jobs as clinicians are more complex if a patient is having psychosocial issues because not only does it impact how they're doing, but it impacts their adherence to treatment. So I wanted to share a little bit about our journey here at the American Board of Pediatrics. And when I started here in 2015, we made a determined intention to partner more with patients and families to advance quality, both of the work we did at the board and to push quality as a priority for pediatrics. And this is a picture of the parents and young adult patients that came here for 2 days to think with us about how we could better partner with parents and young adult patients and what they needed. And their recommendations were that we needed to focus more on behavioral mental health, particularly for children with chronic medical conditions. Also, we needed to focus on transition to adult care. And the third was we needed to work on building communication skills among pediatricians. And coming out of that discussion, we actually cataloged some of their stories to share in a project we undertook with the National Academies of Medicine to provide some testimony on the impact of behavioral mental health on children with chronic medical conditions. And coming out of that, 3 of the parents who'd been at the meeting wrote and said, we believe there is a valuable opportunity for the ABP to address the importance in terms of emotional support and mental health for children with chronic illness, and asked that the board consider investing resources to truly generate a roadmap, hence the roadmap project. And because a picture is worth 1,000 words, I'm going to just share with you some of those parent voices with respect to their interest in behavioral mental health.
Chronic conditions, chronic illness for kids and for parents is really, really hard.
It's a life of constant worry, and it's hard. There's some really, really hard times, and it's 24/7.
It requires constant 24/7 management. It takes no holidays. There's no breaks. It doesn't go away on your birthday. It doesn't go away because you go to Disney World. It's always there.
When you are raising children with chronic illness, you will feel overwhelmed. I mean, that's just a part of your story. It's a part of your journey.
It takes a psychological toll on you and the people surrounding you.
Traditionally, medicine and pediatrics has segregated behavioral health into the psychiatry realm and hasn't paid attention. But we're beginning to understand that if you don't, in fact, support behavioral health of children and their families, everything else falls apart.
Especially in chronic illness care when the specialty provider is really the primary provider.
We think some about the patient, we think a little bit about the parents, and we almost never think about the effect that it's having on the rest of the family, the siblings in particular.
There are lots of barriers to doing this. One is time.
There's also issues around feelings of inadequacy to address certain issues.
It's just lack of resources.
You are expected to be strong.
Sometimes we, as patients, kind of silo our concerns. And so if I'm going to the gastroenterologist, I'm only going to talk about everything from my mouth down and not my mouth up.
When we went to Children's, they recommended that my sons talk to a mental health professional. And first I'm like, they're not crazy, but I had to get past what I had learned, the stigma associated with seeking out a mental health professional.
The principle of if you're on an airplane and you need to, use oxygen, you always put it on yourself before you put it on someone else. But what I realize now is that until mama has what she needs, that baby can never thrive.
It took me a long time to realize that it's okay to do something for myself and not feel guilty about it.
We get to our pediatrician for the first time with all 4 children. And I walk in, I have one with a G-tube and oxygen. I have one child that's beeping because he hears the machine beeping. He's 3 and he's just beeping. And my pediatrician turned to me and said, "How are you doing?" And it wasn't the how are you doing where people are trying to get their papers and they're not even looking at you. It was stop everything, hold the line, how are you doing? That was the first time someone asked me how I was doing.
What would you do to make this better for another child? And my daughter looked at me and said, I wish that they would have listened to me and asked me how I felt about what was happening.
Well, how are you doing? How's your family doing? I would like that to be just like, you know, you come in and they say, stand on the scale. You know, you're taking your weight, you're taking your blood pressure, it would just be common practice.
There's the, hey, I'm Dr. Crandall, how are you? And there's, hey, how are you? This had to have been tough for the last couple of weeks.
But if we start working with families from the time of diagnosis, very early, so that they begin to understand that their resilience is important for their child, that their emotional well-being is crucial for outcomes for the family and their child, then I think that the care team can take responsibility for partnering with families to achieve this.
Can we always provide everything that somebody needs? No, but can we do something better than nothing almost every time? Absolutely.
We need, in fact, to do this in a learning mode because we really don't know how to do this optimally. It's going to take persistence. Emotional behavioral health is really important for these families.
It's okay to ask for help.
I think we do our children such a disservice by not addressing all the things that they're about and understanding all their needs and their dreams and their hopes. I mean, part of this is seeing the future and seeing a child who can do anything.
Not only are the families stronger, but the kids are better.
So Tom Boat mentioned in the video you just saw that we really needed to think about how to do this in our care settings and do it in a learning mode where we were testing some changes and seeing what happened and sharing those with each other transparently and shamelessly. And he also published this paper with some of his colleagues at Cincinnati, but basically calling out that one of our challenges in terms of really addressing behavioral and mental health for children with chronic medical conditions is that our current child health systems have really responded vigorously to the physical health challenges of chronic childhood diseases, but we've been less consistent about proactively and systematically supporting the wellness of patients and families. And so there are a number of system barriers, as were mentioned in the video, including time, reimbursement, the systems not being set up to have teams that are multi-specialty and include behavioral mental health, even in primary care. Other gaps that the families named were looking like we have to have it all together, stigma, et cetera. But we also know we have a training gap. And that comes from multiple surveys. I'm just going to highlight a couple here. But one recent survey by Corey Green and colleagues that came out last summer demonstrated that among third-year pediatric residents and recent graduates, only a small percentage, 32.8%, reported feeling they had high competence in assessment skills for behavioral mental health conditions, and only 18.9% reported high competency in treatment skills. And an earlier study published in 2015 that was conducted through the American Academy of Pediatrics periodic survey system identified that 65% of pediatricians, including subspecialists, indicated they lack training to recognize and treat mental health problems. We just partnered with Corey Green to do a survey of pediatric fellows who were registering to take the initial certification exam in their subspecialties and looked at some of their perceived sense of responsibility, self-reported competence, and interest to try to get a better understanding of what things looked like at the subspecialty training level. We had about an 81% response rate on that survey with a fairly large sample size due to this national surveys format. And we asked about overall interest in emotional mental health needs of children with chronic conditions. And you can see here that close to 2/3 expressed being very interested or somewhat interested, in the emotional or mental health needs of children with chronic medical conditions. When we asked about their perceived responsibility for assessment of children with chronic conditions of these different areas, we had 74% basically agree or strongly agree that it was their responsibility as a subspecialist to identify any emotional difficulties related to the medical condition. 69% to identify coexisting depression and other mood disorders, 67% for anxiety, 68% for substance use, and 73% for substance use, for suicidal thoughts. So a high level of sense of perceived responsibility for managing this. And yet when we ask them about their competencies, and just to give you a sense of this color coding, orange and purple are very good and excellent, and blue and magenta are poor or fair. But not bad in terms of eliciting parent and patient concerns or anticipatory guidance in terms of identifying a high competency. But they really fall off after that. And I'll just point out that using an evidence-based tool like motivational interviewing, which has been around since the 80s and has great documentation for its use, only 33% of subspecialty fellows felt they were very good or excellent at using that as a strategy to encourage engagement in treatment. And if we look at something like suicidality, assessing the extent of suicidal thoughts, it's somewhat alarming that the second leading cause of death for children 10 to 24 is suicide. And yet we've got 25% of subspecialty fellows saying that their ability to assess the extent of suicidal thoughts was poor or fair. Now, we also looked at these by subspecialty. So the proportion suggesting a high reported interest rate is listed here, with adolescent to developmental and child abuse pediatrics the highest. But you can see that there's a fair amount of interest reported across many of the subspecialties listed here. And then when we look at those reporting a high level of perceived responsibility, again, the highest are adolescent medicine, developmental behavioral feeds, and child abuse. But you can see, again, running relatively high across many of the subs. And neonatology is falling at the bottom, which is not surprising because of the fact that the focus really has to be on the parents and siblings at that point in time. When we looked at high level of reported competency by subspecialty, this is a little surprising that even something like my field, developmental and behavioral peds, many are not feeling like they're coming out of that fellowship with a high competency in these screening and treatment competencies that we provided. So why has training not matched the need? Well, part of it is we have not made behavioral mental health training an expectation among leaders, faculty, and trainees. For residents, continuity, even in continuity clinic, is difficult to achieve. Developmental, behavioral, and adolescent faculty are often consigned to meeting the needs of children with severe problems and are not always integrated into training. Many of our pediatric faculty are not trained to deliver or teach about behavioral mental health care. And sometimes there are a number of barriers to getting non-pediatrician faculty with behavioral mental health expertise available financially or ready to participate in pediatric settings. One group we've been working with in the state of Massachusetts that's working with 7 community health centers to integrate behavioral mental health experts have found that often social workers or psychologists are trained in more 50-minute long-term models of care as opposed to more brief interventions that would be more commonly used in pediatric settings. Medical and surgical needs are often our primary focus, and the cross-sector coordination and financing for integrated training, where pediatricians are training beside child and adolescent psychiatrists who are training beside psychologists and social workers, is not happening. So that led us to develop this roadmap package, and I'm going to go through some of the components of it, but it is available on our website. Now, roadmap's goals are to build awareness, both among patients and families, to validate the stress they're going through and promote self-care. And this quote over here again just highlights what one of the parents was saying. We want to seem to have our act together, even though we may only be holding on by a thread. And I will just add that several of the parents said to us, who were not parents of color, that they were worried if they looked like they weren't coping, that their children would be taken away from them. So these are very real fears about holding things together. We also wanted to build awareness among clinical teams so that we could make the decision to proactively and with intention systematically address behavioral mental health. Our second goal was to provide resource and connections for clinicians, families, and training programs, and then provide infrastructure to support and implement change. So in terms of building awareness, we've developed a part 2 activity that can be accessed if you go into your portfolio, where it goes through different literature related to behavioral mental health needs of children with chronic medical conditions across a variety of conditions. We also developed a change package, which is basically an intervention that's developed to be used in QI initiatives that includes a key driver diagram, which is basically kind of a conceptual framework for what kinds of strategies you're going to be implementing and how you see those as making change. And here's an example of one of the drivers, building awareness, that includes kind of the name of the driver, the rationale, and potential resources to employ in addressing that change. Much of this change package drew on the literature, what we knew about interventions that worked. And I'll just call your attention to this report that came out from the American Academy of Pediatrics in 2019 in the journal Pediatrics, which summarizes some of the literature and interventions around psychosocial needs, and just really commented on there are ways to build and sustain resiliency, building off of what we know are protective factors and successful interventions, including cognition and language skills for the child, but also self-management skills, having some sense of control about what you can control with a disorder, helping to build self-esteem, like Mel did going out and visiting this 7-year-old girl's classroom. Talking about physical activity, sleep, nutrition, both with the child and with the caregivers. Helping families to think about how they do positive parenting and interactions. Thinking about creating skilled team-based care systems that start, as Tom Boat mentioned, at the very beginning when a diagnosis happens, and makes discussing behavioral mental health normative and not something that's penalizing or looking to kind of catch you as not being successful in parenting. Incorporating principles of shared decision-making into how we give care, integrating mental health into all of our conversations, conducting screening and surveillance, and participating in practice transformation strategies and QI activities to make change. And then also identifying and building community linkages. And sometimes these are things like early intervention programs and schools and mental health professionals. But I also want to call your attention to the numerous parent and patient advocacy groups that are out there. Oftentimes I've heard from parents and caregivers as we've been talking about roadmap at different institutions in different settings, that it's been other parents who've helped them the most in terms of navigating their own experience. So don't forget about that as well. Now, when we first started introducing roadmap, we heard from a couple of people things like, well, I haven't really asked patients or families about emotional health, or how do I start having these conversations? So those were kind of questions about me at the individual clinical level. But we also heard questions about how do we do this on a systematic basis as a clinical team? So our centers are going to start an annual anxiety depression screening for teens. How do we explain this? How do we talk about this? So we developed a couple of other resources that are on our website. One was a brief 23-minute video on how to start conversations about emotional health. I'll be sharing some of the tips from that with you, but it's really excellent, and I think addresses some of what we were hearing from parents were also communication skills that were lacking among pediatricians in their experience. We also developed 4 example practice conversations that are with real live doctors and actors that we brought in to be young adult patients and or caregivers. And there are 4 different situations, one with a newly diagnosed condition in a child, talking with the parent and caregiver, another with a young teen and a parent, another with talking about routine surveillance and why it was incorporated into the clinic, and then this one, which is inducing depression screening for young teens, and how to talk about it in a way that, again, normalizes it and doesn't say, I've identified you for X reason for being screened. Each of those has also role-playing scenarios that can be utilized in the training settings to take an example conversation, pair off with someone and practice, and learn from each other in terms of what worked and what didn't. So here's an example sample case that's included with those role plays. You have a 14-year-old boy with hypoplastic left heart syndrome who's had 3 surgeries and also has asthma. He's acting out in school. He has low grades with concerns about flunking out. He's argumentative with his parents and been described as moody and irritable. He has cushingoid features secondary to steroids, and he's overweight secondary to asthma, his difficulty with exercise, the steroids, and just his body habitus in general. And how would you, in that situation, start a conversation about how was he doing? And then we have some guidelines for kind of discussing the role-playing situations afterwards, not just in terms of how, what you could learn from it, but also putting yourselves in the shoes of both the clinician and the parent. And then the last goal of the roadmap project has been to provide infrastructure. And we've been pilot testing the roadmap project with a number of learning networks, the Cystic Fibrosis Foundation, the National Pediatric Cardiology QI Collaborative, Inflammatory Bowel Disease Collaborative. And we've also been testing it in 9 residency programs across the country and hope to be sharing some of those lessons learned in the upcoming 12 months. We're taking lessons learned from both of those learning collaboratives and putting them together in a Part 4 activity that we hope people can utilize to try to do this in their own residency settings or clinic settings. So what can you do? That's what we're doing around Roadmap. What can you do? So one of the first things I wanted to comment on is something that the mother of the child with 2 daughters with type 1 diabetes mentioned, which was having a growth mindset about the children you see. Her point about our children are the future. Let's envision a future for them that is one of health. And the WHO defines health and has since the 1940s as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And I don't know what UCSF is like now, but I feel like often my training, whether at UCSF or UNC where I did medical school, the message was we were looking to get rid of disease or infirmity, and less about kind of actually envisioning that child as an adult, that we were partnering with the families to have that child be the most successful adult they could be. I wasn't often thinking about emotional resilience either, what I did as a physician would help a child or a family be able to adapt to stressful situations or crises that are inevitable when you have a chronic medical condition. So start with that kind of a growth mindset. I also wanted to walk through some of what Erica Sood in the video I mentioned talked about in terms of asking how you're doing. So she posits that there is a 3-part strategy that we can take: normalizing, asking, and pausing. And normalizing is really just communicating that emotional difficulties are common and expected. Setting up the discussion so that an easy answer is to acknowledge the emotional difficulties, and moving past the "I'm fine" comment that most of us make just out of social niceties. So examples of how to normalize that would be, I hear from families a lot that after a child has been diagnosed with hypoplastic left heart syndrome, it can be very difficult to know how to explain that to families or to maintain your relationships with families and friends, which are pretty important for getting through what's a pretty stressful time. How are you doing with that? So that communicates, I've seen this often, or this is pretty common, I'm normalizing it, and it sets up for the opportunity to discuss that. And then ask open-ended questions like, how are you doing? Or what's that been like for you? Or has that thought ever crossed your mind? Avoid checklist questions, which are commonly written in on screening forms. Start relatively simple, less can be more. And then pay attention to your nonverbal communication. That came up in the video several times. Don't be looking over to the side or wrestling papers or logging into the computer while you're talking, but actually be making eye contact and demonstrating that you are interested in being a healer and not just a diagnostician. And then pause. That communicates that you want to hear their answer. It gives them time to gather their thoughts and decide what they're going to share. This may be the first time anyone in healthcare has ever asked them. One of the parents of a child with hypoplastic left heart syndrome who was 23 said in that entire time course, and they were at a major children's hospital, they were never asked how that child was doing, or informed that that child might have ADHD or learning disability issues related to having had 3 surgeries during the first year of life. Sometimes families are not going to share the first time you ask them, but that's part of what Tom Boat was talking about normalizing this. If it's something that they start to expect, they may open up and share with you. Now, one of the challenges we often think is, well, this is going to take forever. And this is just an example of how quickly that normalized ask pause conversation could happen. I hear from a lot of parents that they grieve the loss of a healthy child when their baby's diagnosed with a congenital heart disease. How's that been for you? And then pausing. Parent, well, yeah, it's been really hard. I've definitely gone through that. Provider, sometimes it helps to talk with others who've been through it. Who have you been able to talk to about this, if anyone? Patient, I did talk to another parent when we first found out that Sam had a heart problem, but I haven't talked to her in a while. Provider, do you think it might be helpful to reach out again? Adjusting to a congenital heart disease diagnosis can be really tough. It might be helpful to hear that others have had the same feelings and what helped them get through it. So you're laying the groundwork. You're not being a mental health provider, but you're helping that parent to just know that you are there. To prepare for that kind of a conversation, you want to know your own resources. Do I have to time this to do this now? Is there a social worker available if there is something that comes up and I want to be able to deal with it? What are my space situations? If I ask this in front of the adolescent child, how the parent is doing, how's that going to go? Recognizing that screening, which many of us have moved towards, asking people to complete screening tools is not the only tool that we have. It's one part of our larger model of care. Recognizing that active listening is actually an intervention. There is a really strong, the largest randomized clinical trial of depression treatment in adolescents that was conducted and funded through the NIMH that found that active listening and active monitoring actually did quite well compared to placebo. and also compared to cognitive behavioral therapy with or without medication for addressing major depressive disorder in adolescents. So recognize that active listening is an intervention and active monitoring over time. You're normalizing what someone's going through and helping them to feel safe in sharing their concerns. And sometimes just sharing their concerns is enough to help with some of the problems that they may be having with sleep or anxiety. Ask about their current supports. People don't expect you to be a mental health provider, but they are expecting you to be a human being. And if you do screen, have your team ready. Now, that might be your referrals to behavioral mental health. And in 35 states, including California, there's now a psychiatric child health access line where primary care providers and sometimes subspecialists can access free supportive care for kids who are under public insurance and in some states under commercial insurance. But I also really want to encourage you to look out for these parenting groups and young adult peer groups. So they can be very effective. There is a group of 13,000 young adults now called Youth Move National that are organized around helping support other teens who have behavioral health mental issues to go through those. So those groups are out there and they're interested in helping. Then fourth, you can plan proactively and systematically for what you're going to do in the clinic. So you want to be ready and have it built into your system how you will address the demands, stresses, and behavioral consequences from the time of diagnosis. The cystic fibrosis clinic that Tom Boat is affiliated with at Cincinnati has really taken a look at what they had in their care model and realized they talked about nutrition, but hadn't talked a lot about exercise or sleep, and have worked hard to add those in, as well as building in stress reduction and simple things like visualizations and mindfulness breathing to help when someone, a patient or their family member is feeling stressed. Recognize that family adherence to recommended therapies is dependent on family wellness and resilience, both in the younger age when the parent is the one who's doing the therapies or making sure medications are taken, and in the adolescent time period as adolescents take on more of that. And then partner with other providers to promote family wellness and consider doing your own QI project on this area. And then fifth, I think we need to be aligning together to repurpose how we train. So we could embed mental health expertise in primary care experiences to both teach residents and train pediatric faculty in a train-the-trainer model. We could think about longitudinal outpatient-centered rotations through general peds, adolescent, DBP, or child abuse, but also in the subspecialties, where in the outpatient setting or the inpatient setting. We can look to embed psychologists, child developmental specialists, community health workers, or peer navigators into our subspecialty training settings. Think about how we set up meaningful child psychiatry rotations that don't lead us as pediatricians to just want to refer out to the child psychiatrist, but understand what our own role and scope can be. Come up with buddy systems for cross-training so that we're experienced in partnering with others. And then I can't bring up enough how invested patients and parents are in terms of helping to think through planning, training, and care delivery. Any of us who've been involved with these large learning collaboratives that are around the country focused on subspecialty care in units or by subspecialty have really seen how parents can be tremendous advocates, great teachers, are willing to help on these kinds of things, and can provide insight that will help make our interventions better. Other examples of things, we are seeing different pediatric residency and subspecialty fellowship training programs think about or try to implement in our conversations with programs across the country, requiring cognitive health behavioral training for all or a subset of pediatric residents that are moving into areas that might require more behavioral mental health skills. coming up with a PALS-like certification course on motivational interviewing, having collaborative case conferences that are co-facilitated by pediatric and child psychiatry trainees with guidance from faculty in both disciplines, helping to develop new assessment metrics and modalities using simulation, virtual reality, resident-to-resident peer ratings, setting up hubs for training in clinical care, building off of what we've learned over the last year around virtual technology and its strengths and benefits. And then coming up with more coordinated care systems of care. So I invite you to imagine trainees spending time with a mental health provider in a PICU or an inpatient unit, where the psychiatrist, psychologist, social worker, and the parent and caregiver are seen as part of the team, and where trainees observe and participate in counseling of families of critically ill patients, where the mental health complications of ICU care are discussed, both within the context of real mental health complications that might occur within the unit, and then issues that might be of concern going home, and proactively discussing stress related to the inpatient stays with families and thinking through resources. Imagine partnering with a behavioral mental health provider and a parent peer in a GI clinic, where you're looking to promote, identify, and treat mental health consequences of different GI conditions, where your recommendations for what you do might be guided by a mental health professional and a parent peer navigator, and where trainees, be they residents or subspecialty fellows, are actively integrating learning around practical skills and tools, medical information such as drug interactions when using psychotropic medications along with other meds, and learning again how to just ask, how are you doing? There are multiple national pediatrics efforts going on right now. The Federation of Pediatric Organizations has really embraced behavioral mental health as a major area of focus. The American Academy has created a number of tools. They've also created in the last year what are their mental health minutes. These are very brief educational videos that are you do not need to be a member to access, so can be used by anyone. They're also developing guidelines on anxiety, but we do have clinical guidelines published on ADHD, depression, and disruptive behavior. And I was really impressed, the section on pediatric trainees, which is medical students, residents, and fellows, this year picked behavioral mental health awareness as one of their top 4 priorities. So trainees are also recognizing how important this is. The Association of Pediatric Program Directors named a behavioral mental health learning community in 2018, and they're in the midst of developing training materials for residency and subspecialty programs in 6 different domains: anxiety, depression, ADHD, autism, common factors, which is a communication skills approach, and substance use. And then at the board, we're working on developing part 2 and part 4 activities. We're working on what are termed trustable professional activities, which are combinations of different milestones that the ACGME requires. One of those being around behavioral mental health. We're relooking at our content outlines, including the subspecialty content outlines, and then we're participating in this roadmap effort. So to conclude, I feel like the time is now to transform both our pediatric training and our healthcare systems and meet the needs of children of all ages, including those with chronic medical conditions. And this quote from C.S. Lewis, I think, is very meaningful. You can't go back and change the beginning, but you can start where you are and change the ending. And I'm excited to have Mel be a part of this effort and totally committed to it. And also want to thank the different team members who have helped to make Roadmap a possibility. And I'm happy to take any questions.
Thanks, Laurel. That was wonderful, and certainly the roadmap's an important initiative that hopefully will have a major impact on the medical, social, and emotional health of our patients as they grow up into adults. I love that slide about that. So I don't see any other questions. I'll throw a couple in here. One, I was curious what the impact of the government assistance programs might be in both the roadmap or in just in general on the whole initiative and trying to get more attention in the behavioral and mental health. You know, whether it's the ACA or some of the child supportive programs.
Yeah, that's a really good point, Mel. We have just brought on to our foundation board. The American Board of Pediatrics has a small foundation. The current CEO for the Title V programs around the country, the maternal and child health programs. He's interestingly also the father of a child with a rare demyelinating disorder who he was told would not be walking by age 7 and is currently playing on 2 baseball teams. So he is very committed to how do we include the patient voice? What do we do to help bring more attention to behavioral mental health and the stressors on families? And I think those are the kind of partners we need to find. The National Academies of Sciences, Engineering, and Medicine, previously the IOM, Institute of Medicine, also has a forum on children's well-being, and we've been pushing to have this be integrated into their agenda as well. And they've also embraced much more than previously, bringing in the lived experience voices of young adult patients and parents. So I think that's going to help move that forward. I think sometimes we categorize behavioral mental health over here, and it's kids we see in primary care that have ADHD or anxiety, and maybe we pick up on depression, maybe we pick up on substance use, rarely psychosis related episodes, and then chronic medical conditions over here, and we've forgotten the two are intermingled. And so I think our other outreach is to child adolescent psychiatry. And then the American Psychological Association is also has a group that's interested in children with chronic medical conditions. So I think some of this is we're often having these discussions in our own disciplines, and we need to really start to engage across disciplines to have a bit of a more seamless and integrated approach. I also think the Biden administration may be more open to this than the previous administration. So a number of us are looking forward to what may come out of that.
Great, thanks, Laurel. There's a question here from Meg McNamara. Given the need for pediatricians across the spectrum to be more competent in promoting social and emotional health, are there discussions occurring at the level of the ACGME and the American Board of Pediatrics to reconsider program requirements around for training around development of behavioral peds and mental health?
Yeah, so the ACGME just concluded doing kind of a multi-year look at internal medicine and revising those requirements. And pediatrics is on the list. We have heard that that might start in as early as November of 2021. We're not sure, though. There's not been any official notification about that. So I think all of us in pediatrics need to stay tuned for when that launches and make sure we are advocates for these needs. Meg and I trained together, and I don't know if Ken Rosenbaum was in the audience. He and I trained together, but he practices in San Francisco. And I remember him saying to me a year and a half ago at the AAP meeting, his visits were well child, mental health, well child, maybe something else, mental health. So I think a number of us are aware that this is an area we're going to have to take on as pediatricians. There just aren't enough child psychiatrists to do it. But that's a great question, Meg.
I can say a few years ago when I was training, I had a pediatric psychiatrist who went into psychiatry because after a couple of years in general peds, so there were so many mental health issues that he decided he could have more of an impact by doing that. So speaks to your point. There's one other question I'll throw in here, and then Raphael, turn over to you. How can health systems which have limited resources, particularly in the pandemic, be persuaded to commit the funds for this? Can this be shown to be cost saving in the short and or long term? Thanks for a wonderful, inspiring presentation.
Yeah, so I think one of the things we've been doing in the learning collaboratives is both the ones with residents and the ones that are in established networks is really trying to start with taking on very small changes. So I do think some of these things, finding out if there are any parent support groups in your area, or who the national parent support groups are that relate to diseases in your condition. Practicing some of these questions, having a journal club on some articles around this can at least start to build awareness and build some support into the system. Your question about are there cost savings is a really good one, and is probably something we ought to be arguing to NIH should be funded, or PCORI, or a CDC, AHRQ, and making the case that that's needed. And I don't know how many of you know Diana Bianchi. She's the head of NICHD right now, but she would probably be a good place for us to start having that kind of conversation.
Laurel, I'll thank you myself for this wonderful presentation, and look forward to seeing you in person in San Francisco. And Dr. Hirsch, you have a few final words?
Yes, I want to lend my thanks as well. Dr. Leslie, that was really inspiring. I do have one question. We have a couple of minutes left, so I'll try to be quick with the question. But really what your focus today was on our pediatric population, but a lot of these issues also apply broadly to how we, as medical professionals, care for the well-being of our patients. You know, we've really moved since the period of the Enlightenment in the 18th century to thinking about medicine as treating organ systems, the heart, the kidneys, the lungs, and away from the concept of really being a holistic approach towards treating the soul and the spirit and the mental health needs of our patients. And so I'm just wondering what your thoughts are about more broadly how we as a profession need to address this issue more globally.
I think this year has been a very complex and hard year for multiple reasons, but I do think there are conversations happening both with respect to what we've seen with COVID and the impact on families, as well as what's happened with respect to racism, pushing the House of Medicine in general to think about what is our role. And I think I'm hoping it's enough of a push that it moves us in that direction, and that we've had enough of a disruption that's been awful and hard and complex, but that also is enough to kind of push us to really pull back and reflect on what healthcare is in this country and how we practice it and how we interact with patients. And I honestly feel that if you think back to what you wrote in your essays, and I think most of us were not trying to BS our way into medical school. It was to be healers, and I think some of the burnout we're seeing is partially related to the fact that it's gotten harder within the current system to be healers. And if we are trying to move in that direction, even in small ways, even having these small conversations like the one that I showed you, that's going to be healing to us as well, and may address some of those burnout issues. So I don't know if that exactly answers your question, but I do feel we have the potential to be in a place where we're pushing for change.
Well, thank you. This has been great. A lot of food for thought, a lot of things to hopefully look forward to. So thanks again. And Mel, thank you for leading the grand rounds today, and wish everybody a good rest of your week. Take care.
Thank you.